Hello, good evening.
Very good evening.
Hi, Dhirain.
Yeah.
I'm Naveen.
Yeah, I know you. So everything is set. I think still
Well,
panelists are not there.
yes, I'm a little confused because it looks like from the chat this morning, it's going to be more of a panel discussion rather than a presentation.
Yeah. In fact, for past almost 5 years,
Mhm.
we keep more over a panel discussion. What we found that many times we don't convey the presentation also. We don't tell the cases also. So the people in their field, like this is my 25th year of ICU.
Mhm.
So they know what is the spontaneity comes looking at the cases and looking at the management. Otherwise, people start reading the slides. If you keep the answer, they start narrating what has been given in the slide. So in India, people want that, okay, what can be practically done in this type of presentation, this type of cases? Means everybody knows these are the guidelines and these are
Mhm.
the, doggone perfect ways to manage the
Mhm.
patient. But people are interested, okay, you'll end up in this problem. So
Mhm.
how you got out without using technology? What is the use
Mhm.
of technology? And what is the futuristic way we can do better?
Mhm.
So we have changed our for past almost 7 years, even in our national conference, we have shifted to the panels,
Okay.
and and it is the Mahesh idea that he never conveys that what is the case, what are the cases. But this time
Mhm.
I thought that this is an international one,
Mhm.
so I put up the cases. Normally we don't tell them what are the cases, but we try to be realistic. What is the
Mhm.
actual case presentation? Hi, Pompa. Dr. Pompa, Dr. Neeraj was remembering you. You know
Oh,
Neeraj Gupta?
yes, very well. I do know him.
Yeah,
We
yeah,
trained
yeah.
together. I
He
was in Delhi up until 2010.
yeah. He told me. He told me. Actually, I joined in '97 in Gangaram, and
Right.
Neeraj joined us around 8 years back, and so he's the youngest lot of us, and so he was talking highly about you.
Oh God. I hope I can
Yeah,
live up to the expectations.
yeah,
It's
yeah.
under
So,
pressure.
So
Uh,
I'm really sorry, Pompa, but your presentation is absolutely amazing what you put in. And normally, as I was discussing with Naveen, that past 7 years we have shifted to the panels because what we want that whatever practically can be done in these patients means should come first on presentation. Sometimes we put in ideal things which should be done,
yeah.
and many times some types of technology is only applicable to 2% of the patients. So we just want to know, okay, have you done this type of like continuous SCVO2 monitoring? It is written in books, but hardly anybody does continuous SCVO2 monitoring. In emergency, nobody does SCVO2 because you don't put in center
No,
line.
we
It
don't
takes
put in
around
some.
1 hour, 2 hour, but you
Yeah.
put in an endpoint as SCVO2 as an endpoint. So people want to know in this situation how the intensivist got out without technology, with technology, and with high tech. And you all know that, we all know that technology has got its own limitations and all that. So we try to speak our mind so that people catch those things. Okay, this is very useful. I am going to use this technology if I need. So we try to show them what is better management clinically. If you apply non-invasive technology, if you have invasive technology, you can apply. So everybody get something out of it, right?
Yeah.
So, but
So
we'll
I'm
invite you someday to our unit and maybe online, and you
yeah,
present your presentation. That will be, good for them.
yeah, no, whatever is convenient. I mean, I don't mind either way. And I think we didn't get a chance to speak before. So whichever is appealing to your audience, I'm
Yeah.
open to, yeah.
So in India, most of the people are, are working in nursing homes.
Mhm.
So they want, sir, before you put in an ultrasound or continuous cardiac output monitoring, everybody manages these patients clinically, right?
Yes.
And after
And I
some
agree.
time, you get to know, okay, what is the benefits, what are the drawbacks, and otherwise, like in
Yes.
our unit, means if I remember 24 years back, it used to take around 24 hours to get in CRRT, right? And now we are placing CRRT within 1 hour of admission. So that type of gap has been, but not in every hospital this is possible in India.
Absolutely.
So you
And I
must be
think,
knowing Shruti. Shruti, she is in
yeah, I
Birmingham.
mean, Shruti is in Cambridge.
Oh yeah, Cambridge, yes.
So she was with us before I joined Great Ormond Street. So I know her through conferences and all, but I like, I didn't train with her.
Yeah, she was my first fellow who passed
Right.
in 2004, I suppose.
Right. Okay.
Yeah, she was my first fellow, and Akash was is a contemporary of Shruti. So they were our first fellows who passed through India,
Yeah.
who passed through this structured program of IAP.
Right. Yeah.
Now it has grown very much, but so Gaush means all these like in cardio that I
Priya.
forgetting the name. No. Our Indian friend in cardio who
Oh,
should a
Aparna.
lot of Aparna Ghosh and
Yeah.
all the and
Yeah.
Joe Bareilly and all these are very good friends and
Yeah. So Joe was my he was my supervisor in Great Ormond Street. I went to Sick Kids on Aparna's recommendation. So yeah, I know them very well. In fact, I spoke to Aparna yesterday. So Akash came to a conference. So and in UK, the Indian community is like small, but we have a group of intensivists. So we do interact quite closely.
So all UK, all UK English people were teasing us on WhatsApp. They are very good friends.
Yes.
We have got common group, Aparna and Aparna Ghoskote, not Aparna, yeah.
Yeah.
So they were all teasing us yesterday when we lost the match.
Right.
They always do like this.
Yeah. No. There are a lot of us now. So that's good.
Hi, good evening, everyone. I'm Dinesh, and
hi, Dr. Dinesh. Oh my God, you are looking so young.
I never just changed look. Hi, Dhiren. Hi, Mahesh. Hi,
Mahesh. I couldn't see right. Mahesh.
I just saw that. And
Mahesh sir, good evening.
I'm Bhivan, and Sachin and Palab. Yeah. Hi, guys.
Good evening, sir.
Hi.
I think we are approaching time, guys. I think it's just 2 minutes, 1 minute. I think we start with the Hi, Dr. Gupta, and welcome to this. Do you want the IAP people to introduce themselves first, and then we go into it, or how do you want to play it? Because I think it's asthma first, followed by shock. So I'll introduce.
Is it
Dr.
shock
Chatterjee
first? I think shock first, then asthma.
No, it's asthma first, then shock. You have asthma and then you get into shock. No,
you first have asthma, then you do shock. Then you have to say what type of shock you're going to go into, isn't it?
You survive the shock, you will have asthma.
The shock we had yesterday, no? The shock we had yesterday from England.
Yeah.
So now we are reluctant to go into shock again.
It will take long time to from that shock. Okay, guys, we go online. Yeah.
Hi, Ramesh. Yeah. I think we are starting in 1 minute. So I was just wondering to start with, Asthma, I'll introduce once you have an initial couple of lines from the IAP perspective for our UK branch. I think a lot of our UK colleagues will join in through the link, but I will introduce Dr. Chatterjee into the forum to start with, and then the people who are in the panelist, Dr. Chatterjee will take over and address it accordingly. I think we have a more or less idea of what we are doing. So I think we are 9 o'clock now. So without any delay, Ramesh, probably if you start the session and then hand over, and then we can get going.
Yes. Good evening from our side here out in India, and good afternoon to all our good friends in IAP UK. I'm not sure whether Dr. Vineet Saxena is around our HST. He has got some preoccupation or some concerns at home, so he's not around. So I take the privilege of just rolling out the program, second CME of the IAP UK CME joint collaboration CMEs happening for the second time. And we have got our President-elect, Dr. Rupendra Kinjavadekar here, and as well as Dr. Bhivan Saha, our coordinator, our lead faculty, always from the UK side. And of course, we have got the stalwarts for the day, the star faculty, Dr. Pallab Chatterjee, Dr. Indu Khosla, Dr. Thiren Gupta, Dr. Mahesh Mogate, Dr. Dinesh Chirla, Dr. Pomba Kreja, Naveen Rao, and Dr. Sachin, and well, many more, Dr. Subramania, and many more are to join. And well, good evening, friends. All my dear friends in IAP, Indian Academy of Pediatrics, whether it's in UK or India, it's Indian Academy of Pediatrics. So it's all my fraternity members. It's quite heartening to see that we are in the second leg of our second round of our CME with our UK branch. And well, this is an earnest attempt to see the perspectives on any illnesses, basically from the other side of the continent, or maybe in the Europe, in the UK perspectives. Maybe any illness, maybe infectious disease or asthma or a lifestyle, any other lifestyle disease. We have different settings out here in these tropical parts, in this part of the world where the tropical illnesses are predominant, and well, the context may be different. And in UK, maybe we have got a totally different approach. Well, it's a learning process for both of us, and getting to know what exactly is happening in the UK. And for our friends in UK, what exactly is our approach to the take here in our part of the country? I'm sure that this is going to throw more insight to all our friends on the aspects, various aspects of the bronchial asthma and other infections, the stroke and other domains which we are going to discuss here today. So well, it's over to my beloved friends. And before that, Rupendra, would you like to comment some one or two lines, and then we'll ask Pallab or Bhivan to take over. Please, Rupendra.
Yeah. Good evening, everybody. Thank you very much, Dr. Ramesh. So it's a great honor to be part of this wonderful Indo-UK CME, and looking forward for great academic deliberations. All the best. Happy learning to all of us. Thank you so much.
Thanks, dear Rupendra, and I'm sure Bhivan, can we ask Dr. Pallab or who is going to take over?
Well, I'll start it. I'll just introduce Dr. Chatterjee into it. I think it's got quite a tight schedule, so let's start going. I will start with asthma, day-to-day management of asthma in pediatrics, and we have quite learned faculty here. So I'm just going to introduce the moderator for the asthma section is Dr. Paul Chatterjee. I've known him for ages now, and now on different parts of the world we are practicing. He has been a member of the Advisory Committee of Vaccination Immunization Practices, IAP 2018-2019. He has been the Secretary of West Bengal Academy of Pediatrics 2018-19. He's in the European Diplomat of Pediatric Respiratory Medicine. He is a member of the Executive Committee of the IAP in 2020. He's the Scientific Chairperson of the West Bengal Chapter of Pediatric Pulmonology, and he is one of the founder members of the National Respiratory Chapter of Pediatric Pulmonology. He's authored several books and chapters in several books on postgraduate textbook of pediatrics, IAP textbook of pediatrics, and IAP textbook of tropical pediatrics. He's got an extra feather to his cap. He's the chairperson of the Computer and Medical Informatics chapter as well of the 2021-22 IAP. So with all these laurels, I'll hand over to my good friend and very senior Dada, Pallab Chatterjee.
Thank you, Bhivan, for your lovely introduction. And I'm sure my mom would not have recognized me after hearing all this. So whatever you said. But anyway, it's fantastic meeting you after such a long time. And I think I will start sharing my screen. Is it visible?
Yeah.
Okay, so our first panelist here is Dr. Naveen Rao, and he is the honorary senior lecturer, consultant pediatrician, and deputy clinical director of acute and general pediatrics of Royal Manchester Children's Hospital. He is the lead of pediatrics, cystic fibrosis and allergy at Wythenshawe, and he is the associate dean of staff development, Manchester Medical School, Wythenshawe Hospital. He is a member of the British Respiratory Society. He is a member of a British Society of Clinical Allergy and Immunology and the European Academy of Allergy and Immunology. He is also an active member of the Northwest Allergy Respiratory Network and the Northwest Cystic Fibrosis Network Group and the CF Transition Network Group. He is also a member of the Great Manchester and the East Cheshire Strategic Clinical Networks and the National CYP Asthma Data and Digital Working Group, working to improve the asthma care pathways across the northwest of England. So we are eagerly waiting to hear from you, like about your perspective of how different or how similarly we manage asthma over here. Dr. Subramania was our opening batsman, but unfortunately, as usually happens in the Indian team, our opening batsman got out for a duck. So probably he'll be back. He's not well. So he said he'll join. He was supposed to be the moderator, and I was the replacement. So I am the 11th man on the field, and he will be back as a panelist. That's what he has said. And I don't think we need to.
Pallab sir, today don't talk about cricket.
that I leave to you. You have to discuss about shock.
We are mourning. We are mourning at the moment.
We don't want to hear the word cricket.
And I don't think we need anybody in India needs any introduction to Dr. Indu Khosla. She is the European Diplomat of Pediatric Respiratory Medicine, international sleep expert, and a diploma in pediatric sleep from the University of Colorado. She's got special interest in flexible bronchoscopy, sleep medicine, and mucociliary disorders. She's been the core faculty of most of the respiratory modules of IAP, the national convener of the NAPS module on sleep, international advisor to the Congress of International Pediatric Pulmonology, and she has established a level 1 sleep lab for sleep disorders in Mumbai. She's delivered multiple lectures and has got multiple publications, and she's attached to the Lilavati Hospital, the NHSRCC Hospital for Children, and she is also the director of Dr. Indu's Newborn and Child Care Center. So welcome, ma'am, to the center, to this CME today. And I don't need to introduce myself. We will go straight into the definition of asthma. So we all know what is asthma. It is a chronic inflammatory disease of the airways it has to be episodic and or chronic symptoms of airway obstruction. There has to be bronchial hyperresponsiveness to triggers, and there has to be at least some sort of a partial reversibility of the airway obstruction. And you have already excluded the alternative diagnosis. So now let us come to a typical case that we see in our day-to-day clinical practice. So a 2-year-old child, Raju, with a history of recurrent wheeze and cough, has got 3 episodes in the past 8 months. Each of these episodes were preceded by fever and a runny nose, followed by cough and wheeze, lasting for only up to 5 days. There were no interval symptoms, no prior symptoms. There was a family history of allergic rhinitis in the father, and the mom had asthma as a kid. Examination, the child was otherwise normal. So with this, as the Bard said long time back, that what's in a name. So what would you say that this is what is the likely diagnosis? Should we call it an uncontrolled asthma? Should we call it under 5 wheeze with a high probability of asthma? Should we call it just an episodic viral wheeze? Or because of this is happening regularly, we have seen prescriptions with saying that it's a recurrent bronchiolitis. So I'll start off with Dr. Indu Khosla, ma'am. What do you think is the diagnosis in this child?
This child has had 3 episodes already, and there is a very strong family history of asthma in the mother as well as allergy in the father. So the history is there, the number of episodes are there. The only the here it seems that it is mostly viral triggered, because this child each time had fever, and then the child landed up with these. So I think, to make a diagnosis at times at this juncture may not be that easy. One would say, okay, yes, this is a viral triggered wheeze, but there is probably a high probability of asthma given the family history in both the parents. So I would keep my options open, and I would toss between these two, as a viral triggered wheeze and probably with the high probability of asthma, and would like to follow up this kid and see the response probably to bronchodilators. If I had some, more cue that this child responded well to bronchodilators, then I would probably, think more in terms of asthma. So this is how I would handle this child, and I would probably follow up this kid and see which way we're going.
Thank you. Dr. Rao, anything different you would do in your setup?
No, I think I would agree with Indu's assessment. The history is very typical of a viral wheeze with preceding infection and lack of interval symptoms. But then there is the risk factors that are there, the A to P in the family. So I wouldn't completely discount the likelihood of this child developing asthma. And I think I would just like to bring to attention the excellent and now quite old two-SCON cohort study from Arizona, where they looked at over 1,000 children and followed them up for over 20 years now, where they identified the so-called wheezy phenotypes. And so it's very likely this child, is in the 50% that would wheeze before the age of 5, but would settle. But the only time will tell. Unfortunately, we don't have a crystal ball which will tell us how likely it is that he's not going to develop asthma.
Yeah. So, I think for our viewers over here, we would like to say that we should stick to a fixed sort of semantics, writing any sort of diagnosis on the paper saying that it's recurrent bronchiolitis or it's a asthmatic bronchitis, and all these names should be avoided as much as possible, and try to stick to whatever. And as Dr. Rao was saying, these are going to change over a period of time. We have to keep our minds open, and we have to watch out, and many of them might develop asthma, or many of them can again go back. So the arrows go both ways. And over here, what we do is we follow mainly the GINA guidelines, and that has been taken up by the ATM, the Asthma Training Module of the Indian Academy of Pediatrics. Dr. Rao, what do you do there? What do you follow the GINA guidelines, or do you have any other?
Well, the GINA is a relatively new initiative. So in the UK, we've had the British Thoracic Society guidance, which has been around for over 2 decades, and was to some extent called the gold standard. I think the same group that was involved with BTS then got involved in GINA as well. We tend to use the BTS sign, and now we have the National Institute of Clinical Excellence guidelines. So there is some discrepancy between the 2 guidelines. But the key thing, I think all 3 guidelines says is, you're absolutely right that we should avoid semantics in terms of, confirming a diagnosis. But at the same time, they say that based on your thought process, if you think it is asthma, you could document that as a diagnosis. And again, systems are different all over the world. So, a lot of it is tariff-based practice over here, and in the further west you go. But as long as you can justify your rationale for treating somebody, I think that's the key thing that, all the guidelines sort of suggest, that there's no harm in doing that. And in this particular child, the fact that there's a high risk of A to P in the family, there's 3 episodes where there's obvious wheeze. I'm assuming there was also response to treatment. You could justify, as Indu did right at the beginning, to say there's a high likelihood that this may evolve into asthma, and I'm going to monitor this child.
Yeah, so many of these children, most of them will have asthma. That's what GINA tells us. So we have to keep our eyes and ears open for this child. Raju comes back after a year with acute exacerbation and is seen in the emergency now. So he's alert, he's got minimal subcostal indrawing and some tachypnea, saturation is around 94% in room air. He's got bilateral extensive wheezing. So what would you do in our setup? Like people say that you give salbutamol through our MDI with spacer and a mask in this child, even in an emergency. Many pediatricians practice salbutamol nebulization using the compressor, and oxygen-driven salbutamol nebulization is also advocated, and salbutamol plus ipratropium nebulization is again, and even they are available as a single vial, so it's mixed in the single vial. So, Dr. Indu, what would you like advocate for such a child?
So I think if you go back to the previous slide, if I were to look at a pulmonary score index for this child, he has minimal subcostal indrawing and tachypnea, and saturation is good, but he has extensive bilateral wheezing. So he would come somewhere in the moderate category of wheezing and not really the one who really need an ICU kind of care. And therefore, one could here look at giving salbutamol through MDI, spacer and mask to start off with and see his response. And one could give, your 4 to 6 puffs at the gap of every 20 minutes and keep him in the ER, follow him up and look at giving him 4 to 6 puffs every 20 minutes over a period of 1 hour. So 3 times you would give that, and you would like to watch him, how he's going, whether he's responding or not. And only if he's not responding or if he's worsening, then I would kind of move ahead. So my choice here would be salbutamol through an MDI, spacer and mask. The only time I would think of, giving salbutamol nebulization and definitely through oxygen would be if his saturation would have been lower, or if the child is uncooperative or does not take the MDI spacer mask, then my choice would be probably to give salbutamol nebulization, which should be oxygen driven. So this is how I would look at doing handling this child.
Perfect. Dr. Rao, anything different you would do there?
No, I would completely agree. I think the assessment that it's moderate is absolutely right and spot on. And our first choice in any hospital here would be 10 puffs of the salbutamol through a spacer and a mask. And like Indu said, if we are going to be giving nebulizers, then it has to be oxygen driven. I don't know, you've got compressor as an option. I don't know if that would actually give you oxygen, because it's just to highlight, there's definite evidence that, salbutamol is associated with worsening hypoxia. So any delivery of salbutamol, particularly a nebulizer, has to be oxygen driven. And certainly that is our practice here. And of course, the evidence that, 1,000 micrograms of salbutamol is as effective as a nebulizer has been around for decades, starting with the Australian studies in the sort of late 90s and early 2000s.
So do you get these compressors available in your OPDs or in your ERs in the UK where you can give them? No,
we don't have compressors. Yeah.
There
are some parents who will source them over Amazon, but it's not something we recommend. So all nebulizers are driven through oxygen.
Yeah, so patients are the same everywhere, but doctors may differ.
Yeah, the real life and the real life sometimes differs here.
Yeah.
We do have people using salbutamol nebulizations through compressors, and despite us telling parents not to really keep a nebulizer at home, because an MDI spacer with or without a mask works equally well or probably better, but we do have patients who would nebulize the child at home through a compressor and come. So this keeps happening all the time. So there is a difference between real life and real life.
No, but not only that, there are many doctors who keep these machines in their OPDs, and when they get these children, they nebulize them in the clinics. And it's extremely common. And supposing if a parent comes and sees that this is being given in the clinic, then why not give it at home? Why should I pay the doctor a charge? So that is what comes into their mind. So That's what the patients may be similar everywhere, so their thought process is similar. So if they don't get it directly from the pharmacy, they can source it from other sources like Amazon and all. But doctors differ over the globe, so we have to like understand. And do you have these salbutamol ipratropium combinations available, Dr. Rao?
No, you don't have pre-prepared formulations. They're mixed. We do give combined nebs, but they don't come as pre-prepared formulations.
Okay. So he's lost to follow-up. Now he comes back at the age of 5 years. So now he has recurrent history of cough and wheeze, 4 episodes in the last 6 months, each lasting for about a week. And there's been good response to salbutamol, no interval symptoms. So we've been always told by our teachers that asthma diagnosis is always clinical. So now when this child comes to us at the age of 5 years, we write down this child has got asthma. And then do you really think that we need an objective assessment in this child before we label this child as asthma? Should they all have spirometry before starting treatment? And if not available, at least a peak flow meter and look at the variability of the peak flow, and repeat the PFTs once in every 3 to 6 months after initiating treatment. And suppose if you have a normal spirometry, or if it's a child is very young and cannot do a spirometry, do you actually go for, say, airway oscillometry and the others? So I would ask Dr. Indu, do you really advocate doing a spirometry before you start treating, or at least a peak flow?
So this child, the diagnosis is clearly there. It's like staring on the face. It's a clinical diagnosis, and there is no doubt that this child has asthma. Having said that, Gina emphasizes a lot on doing spirometry. Now this is a 5-year-old, so like we're little sitting on the fence. Like, you know, he might be able to perform, he may not be able to perform. In my experience, where we do a lot of spirometries at our clinic, 5 years are only the smart 5 years can really do it. So generally, I would think a child below the age of 6, it really does not give us the best out for a spirometry. When it comes to peak flow meter, it's of course it's not a tool for diagnosis. Of course, it's a great tool for monitoring, and it could tell the patient that you need to have their own best so that they can assess themselves. So they need to record it, you know, morning, evening, over a period of at least 2 weeks, and come to know their personal best, and therefore they could, you know, assess themselves in case they're getting a breakthrough. Well, again, of course, ideally can be done, but it's not, again, universally done in our country for sure. If I have to choose between spirometry and peak flowmetry, I would choose spirometry because it helps me monitor this child when I want to step down treatment. It's again helps me the correct time to decide when I need to step down the child on therapy, and therefore one can repeat it once in 6 months, or if the child is not under control, or when I want to step down treatment, or when the diagnosis is in doubt. Suppose the child does not give a correct response to the treatment that we have given, and we have a diagnosis in doubt, and spirometry becomes a great tool. Now, airway oscillometry, again, I do have the device at my centers where I work, but the problem here is that we still lack normative data. Though it's very simple, the child has to do a normal tidal breathing, and it just with the principle of sound waves you have used in medicine for donkey's years, be it for ultrasound or for many other places. So normative data is lacking. Only for obstructive disease, it picks up small airway obstruction better than spirometry. So sometimes you may have a normal spirometry and you do an impulse oscillometry, you may pick up a small percentage of children whom you have missed on a spirometry. But I still think, though it's a very, very, oscillometry came way back in 1956 when Du Bois first, talked about FOT, the forced oscillometry. But it's still to see the light of day. And I think many places we are still not using it. we still need, we need to interpret it better, because many of us even lack the ability to interpret a reading of a impulse oscillometry. So therefore, it's still to see the light of day. Maybe in times to come, it may be a good tool for younger children, where a child about 3 years with normal tidal volume, we could assess any obstructive disease and even look for reversibility by measuring the reactance, the resistance, the impedance, etc. FeNO, we know asthma is a heterogeneous disease and it has different phenotypes. So the FeNO would help us identify an eosinophilic phenotype, right? So to some extent it might help, but again, it's not the best and the most optimum investigation, because we know there could be different phenotypes and your FeNO may be normal and you may still have asthma. At best, if you have an eosinophilic airway and the child is on inhaled corticosteroids, if your FeNO levels are well below 33, so then maybe that the child is compliant with inhaled corticosteroids. So it has some role in monitoring and following up patients who are on inhaled corticosteroids. So I would do a spirometry as and when I can. I would be in that space. So I would do even for diagnosis and following up these children. Yes.
Dr. Rao, your take on it? Like, what do you
I
do
think,
there?
well, so what we do and what is recommended here, certainly NICE has recommended objective testing. So with spirometry, exhaled nitric oxide, and the rationale for that. So the remit for NICE is the cost effectiveness of a particular treatment. So the idea being you need to be absolutely certain you've got the diagnosis right and you're not unnecessarily labeling somebody because of the long-term implications of that diagnosis. So that is their rationale for going with objective testing and recommending objective testing. Whereas BTS Sign has always had a very more pragmatic approach. Yeah, if your history is consistent with asthma, you're responding to asthma treatment, treat it like asthma. And that's where there's a slight discord between the two guidance. And I think Gina has taken the middle ground of the two, and BTS Sign and NICE are now coming together to come up with a more a combined guideline, which they're hoping to publish this time next year. In terms of objective parameters, again, the problem
a combined guideline of BTS and NICE.
Yes, that's right.
Okay,
yes,
okay.
Which will come next year, which will look both, at the evidence behind a recommendation, but also the cost effectiveness. So they're merging their two sort of key remits. Okay. So the problem with any such condition, ideally you would have liked a patient turning up with the label on their forehead saying I've got asthma, but it isn't. It's about information finding, and as much information as you can get is the best to aid your diagnosis. Unfortunately, with history, there's a lot of subjectivity, both in what is told to us, as well as, in terms of what it assesses. Even V's, there's a huge heterogeneity, not just amongst parents, but even clinicians as to what constitutes a V's. And so there can be that, subjectivity to it. And that's why the objective assessment comes in. But the caveat to that is, to do spirometry, the person doing the spirometry needs to have proper training to do it so that it's standardized across the board. And it's the same with peak flow. I know a lot of my professors in the UK who don't believe in peak flows because they feel that patients can fudge their peak flows. It's sort of very user dependent and not that reliable. Exhaled nitric oxide, certainly it's good for diagnosing eosinophilic asthma. If your level is about a certain, if your FeNO levels are about 35 parts per billion is what we use here. But we've just contributed to a multi-center study, which is called Rakino. So it's looking at using exhaled nitric oxide levels for monitoring and escalating treatment in asthma, and they're actually publishing. So it's in the press at the moment in Lancet, which should be coming, and the results were shared. And basically, it wasn't superior to just good history taking. That was the sort of conclusion of the study, a large study run from Aberdeen by Steve Turner and his group, and we contributed about 15 patients to the study. So, yes, any information is useful, but it needs to be taken with a pinch of salt.
Okay, and do you use airway oscillometry at all over there?
No, no.
So this was the spirometry. Dr. Indu, can you just elaborate, because we cannot have anything on asthma without discussing a little bit of spirometry. And this was the pre and the post.
Yeah. So if you see the FEV1, the predicted for this child based on his weight and height was 1.64, and he did a 1.29, which increased by 52% to 1.96 in the post bronchodilator. If you look at the FVC, so it predicted was 1.87. His pre was almost as good as his predicted. That also did go up post the bronchodilator by 23%. It could mean that there is severe obstruction, so your FVC also could be a little lower. And if you see the FEF 25 by 75, that showed a jump of almost 214%. This tells me that small airways are significantly involved, the FEF 25-75. So definitely this is clearly an obstructive disease. Yeah. And in children, in fact, if you have an increase in FEV1 even by up to 8%, I would consider it significant. And like adults would say 13% change, but here even in 8% in children would be considered significant. So this is clearly an obstructive disease, significantly, which probably suggests asthma here. Yeah.
And anything about the oscillometry that you do there?
Here, 1 second, I need to wear my glasses. This very small print.
No, it's okay. It's not that important that we always think about oscillometry, but yeah.
Yeah, if you look, what we need to look at is your resistance at 5 Hertz and X at 5 Hertz, and you look at the predicted and you look at the post change after the resistance at 5 Hertz, and where if it is more than 40%, it considers significant. So it's like a 51% here. So this is a definitely.
It's definitely
significantly. Yeah.
So it does, and you use the impulse oscillometry, or you use the tremor flow?
So we use impulse oscillometry more than.
Okay.
Yeah.
Okay.
So I also need to tell you that most of our centers really are not using it. Even spirometry is a far cry.
Absolutely. So at least
I might sound a little. So I work in a tertiary care, so we do have the liberty and access to all these things.
Correct.
But I don't want to give a false impression that we are really doing it for all our patients. Even spirometry is a far cry. Yeah.
So at least we should try and do a peak flow. So something at least, even in the remotest of centers, remotest of clinics, we can do. Now this guy Raju again comes back 6 months later with persistence of wheeze. He has had an episode of cough and wheeze almost every month, requiring oral steroids. And there's a history of cough on running and laughing in the interval period. So whenever he runs and laughs, he starts coughing, and otherwise he's asymptomatic at the present moment. So the mother says that our child gets better with salbutamol inhaler every time he has a wheeze. However, he seems to need it very frequently for a while nowadays. So is it okay? So is there something wrong that we are missing? And this management with frequent short-acting beta agonists and SOS short course of oral corticosteroids. So why is it unacceptable? What is happening, Dr. Rao? What do you think is the problem here?
Well, I think the problem is he's not on the right treatment. So I'm not sure. Is he just on short-acting bronchodilators, or is he on preventers as well?
Yeah. So what's happening is the parents feel that once they give the salbutamol, the child improves. So they stick to salbutamol only. So they choose that inhaler rather than the other one.
So he has been prescribed a steroid inhaler as well.
Yes.
Yeah.
Yes.
So yeah, this is unacceptable. So I mean, certainly his symptom profile, and so-called asthma control score would suggest that he's very poorly controlled, and he needs to go on to regular preventive therapy. And there's going to be a huge piece of work that would need to be done with this family to highlight the importance and educate them on the role of inhaled steroids in preventing asthma symptoms. And it's a very common thing. I mean, this is not just India, even in the UK, where supposedly you have educated people, often they refuse to take their regular treatments, and because they see the benefit, the immediate benefit with the Ventolin or salbutamol, and so they think that is the be-all and end-all of treatment. What they fail to realize is the preventer is the one that keeps it under control, and if you take that regularly, you may not need to take your short-acting bronchodilator.
And now Gina has said that after every puff of short-acting bronchodilators, you give one inhaled corticosteroid. IATM IAP module has also adapted that. Do you use it in the UK that every SABA is followed by one ICS?
So it is just coming in. So maintenance and reliever therapy is something that has been around in the adult world for a while. I think it was then the license was dropped to 12, but like you said, and I think the NICE guidance also says that you could use MART therapy.
No, we are not talking about MART. We are talking about the short-acting beta agonist and the ICS. We're not talking about LABA and this
no.
ICS
So this
combination.
is you're talking So you're talking about combined
short acting and ICS.
Yes, and short acting and low dose inhaled corticosteroids as a therapy, as a first line, acutely, intermittently to begin with, and then you might want to give it regularly if you're still needing it.
So I'd like to add a comment here. So when the whole therapy came in by Dr. Martinez and his group based on the Trexa study, where they looked at when they were stepping down from daily inhaled corticosteroid as a controller, and they thought that maybe we could use it with a SABA as and when the patient has a breakthrough while you're stepping down. The other place where they did use it when you had patients who are really non-compliant, and that's the place that they use inhaled corticosteroid along with the SABA. So very, very clearly, even in that article, it's mentioned that the daily inhaled corticosteroid is superior to this intermittent corticosteroid, and it's only in places where patients may not be compliant or in your stepping down therapy, one can consider it. So I guess we with time we will see which way we are going to go, whether we are going to advocate using an inhaled corticosteroid with every exacerbation that the child may have along with the SABA. I don't know really. We were earlier data said that if you use an inhaled corticosteroid, it takes about 2 to 3 weeks
exactly
to start working as a controller. And now we have data to say, oh no, it will work in an acute exacerbation, and you could use an inhaled corticosteroid as well. Well, let's wait and see. Maybe things might evolve. I feel this is a space we really need to watch. Because
and funnily, we had a preparation of salbutamol and beclomethasone available as a combination, and which was available for a long time, is still being used by general physicians all over. And we used to ridicule it, and now people are saying that we use a combination of SABA and this thing, though separately. So.
Dr. Rao, I wanted to ask you, do you use budesonide as a corticosteroid, or do you use beclomethasone?
Beclomethasone is our first line, not budesonide.
Is there any reason? Because whatever data I had made that budesonide. Okay, fine.
Okay. Yeah, because here we prefer to use budesonide because Gina is like, budesonide, and we have adapted that also.
I think Clenil, beclomethasone, the off-label one, basically is it costs like Smarties, sweets, and so cost is the main consideration.
So he is now on a maintenance therapy, budesonide as you prescribe, but he still has persistence of symptoms. He's got good compliance, technique is correct, no comorbidities, and diagnosis is verified and differential. So now what should we do? Should we increase the inhaled corticosteroids? Should we add on LABA? Should we add on montelukast, or there was some theophylline preparations that were available. So should we do that? So Dr. Rao, what would you do in your country?
Sorry, can you go back to the previous slide? So
he's on maintenance now, but still he has symptoms. Yeah. So he's taking
how
ICS.
have we assessed the compliance?
That's what we have to do. Like, you know.
So one of the biggest.
So let's take it that he is compliant. Yeah.
Okay. So if he's compliant, then probably, and he's now, how old is he now? 5 years. So probably I would say
5 years, 5.5. Yeah. Or 6 years.
So our guidelines would suggest consider adding montelukast. Or a long-acting bronchodilator. My personal preference is montelukast because it's a different way of taking something. So we do it, but it doesn't work for everybody. And often we get patients, sorry, my laptop battery is running low. Let me just turn on the plug.
Dr. Pallab, I have a thought here. If you go back to the previous slide. Yeah. Now, this is a child who had one severe exacerbation, and he has had multiple episodes of wheezing. I mean, I would not have started him on 200 micrograms of budesonide per day. I think he deserved a little higher dose.
Okay.
And probably since he's 5 years plus, I would have started him on an ICS LABA. It would also have been steroid sparing, and we would have given him a better control and a better faith on treatment of inhalers and improve his compliance. I would have started him on the ICS LABA upfront and not budesonide 200 micro, or alternatively 400 micrograms per day of budesonide would be my thought.
Yeah, but Dr. Rao, over there in UK, they will add on montelukast first.
Not necessarily. So generally, if you're under 5, then the preference tends to be montelukast. But over 5, it would be a LABA. And again, it would be decided on, in terms of interval symptoms, particularly exercise-induced symptoms. So if there are significant exercise-induced symptoms, then you probably would be veering more towards a LABA-ICS combination.
Correct.
Just to make you aware, you've got about 7 to 8 minutes to round off, please.
Yeah. So the next question obviously goes to Dr. Rao, that how do you ensure compliance in your country? Because we failed.
No, I don't think anybody has got the solution to it. And I think the key is education, and more education. So what we do here is a system-wide approach. So the idea being every patient contact. So the system here is set up so you have primary care, your GPs who manage most of the patients, who then refer on to secondary and tertiary care, who then give a plan and send back to primary care. So the system is set up such that whenever a patient runs out of medications, they go to their GP or practice nurse for a prescription. So at that point, that should be a review that takes place. Are you taking a medication? Are you taking it right? Do you know how to take it? Do you know how to step up? Do you know how to step down? But it doesn't happen. So many times patients turn up to our emergency departments where again the same process needs to be happening. That doesn't happen. So I don't think, it's a little bit like our politics. So we've had an Indian prime minister. So, I was hoping you guys could give us some ideas on how we actually can improve compliance. But I think it's just, it's just education, and more education.
Okay. So because Bhivan is after us, we'll go for some rapid fire questions. So assessing lung functions in under 5s, what do you do? Dr. Rao.
We don't do anything.
Okay. Dr. Khosla, would you do anything?
At this point of time, really not anything, but maybe for an odd case where a child is really very sick, I would look at impulse oscillometry.
Okay. And do you do allergy testing in most of these patients, Dr. Rao, in the UK?
Allergy. Not to diagnose the allergy or asthma, but if somebody's asthma is poorly controlled, they're compliant with their treatment, they're taking their treatment right, and you're still not able to control it, those patients certainly would benefit, because again, often there's a coexisting allergic rhinitis. And if you think about the one airway model, it could be that the inflammation in the nose is what is triggering the asthma. So those cases would certainly benefit. Again, if there's a clear-cut history of an environmental trigger, so going into somebody's house where there are lots of dogs or cats, you would consider allergy testing there, but not routinely. We wouldn't routinely do it.
Dr. Indu, do you do routinely allergy testing?
I would completely agree with Dr. Rao. So there are two places when you have allergic rhinitis or in the under 5 wheezers. So you have given a therapeutic trial, and post the therapeutic trial, the child, and you stop it, and then the child starts wheezing again. Maybe there will be some role of doing an allergy testing. And even milk protein allergy sometimes can come with respiratory along with GI tract and skin involvement. So that is one category. Allergic rhinitis is one category. Very strong family history. You have 5% of children who are severely atopic asthma. So these are kids, these are families where they have a lot of allergies. So that's another place where I would do an allergy testing. So uncontrolled basically and severe.
I think we discussed pheno, we discussed exercise induced, and everybody was in favor of MART. And about Montelukast, what are the safety issues? And do you get combinations of Montelukast in your country, Dr. Rao?
No.
With levocitrazine or fexofenadine or something?
No.
No. Okay.
No.
And safety, you're happy. And how long do you give Montelukast if you happen to start a child on Montelukast?
Minimum 3 months trial.
Minimum 3 months. Okay. And tiotropium, have you used? Like, what is the?
I personally haven't yet used. It's only just been licensed and it's only just been recommended even in GINA. I think there was a 14, 15-year-old that I see jointly with the adults where we have used it, but it's not something we routinely use.
So and the youngest child you have used, Dr. Indu?
I have used it in close to about 9 to 10 patients. And these are children who were poorly controlled. And when we have looked into compliance, adherence, comorbidities and everything, and stepped up the dose of LABA and with corticosteroids with LABA, and still the children are not under control. So it's like coming at step 4. And that's the place where we have used it. The youngest kid that I have used it is about a 6-year-old child. Again, a very severely atopic family. The results were brilliant. Okay, yes. I have used really brilliant, but I've not used. We use it for a short time, maybe for a period of 2 to 3 months, and once the child is under control, I'll kind of step out of it. I had one child who had a child with cystic fibrosis who had the obliterative variety of wheezing. He had the obliterative phenotype, and this is a kid who constantly would have a lot of wheezing, a delta 508, and we landed up using tiotropium, to which the child responded beautifully, only to develop very dry eyes, so much so that I had to stop the tiotropium. So this is something which we need to look out for the dryness of the eyes as adverse effects to tiotropium.
Yeah, and it's also a good drug for the cough,
Absolutely.
If you have the irritating cough, the viral coughs, short term.
It works brilliantly.
Just 2 minutes more, Dr. Bibhan, and I'll let the stage off. Biologicals, do you use, Dr. Rao?
Well, so the way it is set up here, it's specialized commissioning. So all patients who require or who are at that stage tend to get referred to a tertiary center, to select centers where it is initiated. That's because of the way the funding stream is set up. So I have a few patients on shared care who are on biologics, and they're the ones who had very allergic asthma with raised IgE, who did respond quite well to treatment and continue to have their infusions.
I have two kids on mepolizumab. This is a child with an eosinophilic airway, and they are about 12, so it just got licensed even for slightly younger kids. But again, the problem with these biologicals is like you keep giving, and once you stop, they're back to square one. And the cost of therapy is also a big issue here. Yeah.
And any newer modes of delivery of inhaled drugs that you are using there, the breath actuated inhalers or something?
Oh yes, so that is certainly we are, so the big thing in the world of asthma here is the carbon footprint of our inhalers. So there's actually a document that's been developed which looks at the carbon footprint, and so the preference where possible is a breath actuated inhaler or a dry powder inhaler. And generally over the age of 8, if a child is able, then we tend to prefer a breath actuated inhaler. But saying that, certainly a MDI with a spacer probably is a lot better if you're having an acute attack, because your tidal volumes that you generate aren't that good, and so it's a lot easier for the drug delivery. So there are some patients where we still continue with the MDI via a spacer.
So even if we use the BAI, we have to tell them that they need to have two of these devices.
Some of the devices that have come in, the Edero, which helps you monitor the patient's compliance through Bluetooth, but I haven't got any personal experience, but they are there in the Indian market.
Okay, so what are your take-home messages for success from the UK to India? Dr. Rao, we would like to hear from you. So what at the end of?
Well, so probably take-home message is spend some time taking a history, because, even though there are objective tests, often, the clue is in the history, and a detailed, there's nothing to beat a detail. It's a dying art these days, in the world of legal medicine, people, relying more on investigations, but there's nothing to beat a good going history to come at a diagnosis. So spend time with the history. The other key message here is, if it is asthma, it should, in most cases, respond to asthma treatment. So if it's not responding to asthma treatment, have you got the diagnosis right? Are they taking the treatment? Are they taking their treatment the right way? So these are the key things that you need to review.
Thank you. And Dr. Indu, you want to add something?
Yeah, if India and England had a common cricket team, we would have conquered the world. Is my take-home message.
Yeah, but India has been able to keep India and Pakistan. England has been able to keep India and Pakistan apart. No, again. Okay, thank you. Dr. Bhivan is getting very fidgety, so thank you very much. Thanks for an excellent session. We're very happy and enlightened, and I think there are a few questions in the chat box which we have missed. So shall we take it very fast? Bronchial asthma
it's mainly comments rather than question, Pallav.
Okay. How to manage shock with CCF in MISC? I think that is coming up. Use of iOS is done. Look for the nose comorbidity. Yes, okay. And referring to the black box warning. Yeah. So black box warning about Montelukast. So I think Dr. Rao is not there. So yeah, there is a black box warning about using Montelukast for a long time. So we have to be very careful because they can develop neuropsychiatric symptoms. Yes. So people tend to use it and they tend to continue it for years together. Thank you. The stage is yours, Dr. Bhivan. And thank you, my panelists, for a fantastic session. And unfortunately, Dr. Subramania could not join. So thank you.
Thank you very much, Dr. Pallav, and thank you, everyone.
Oh, thanks. Thanks, Dr. Chatterjee. And it was really a very enriching session. I think we got most of it as for practical management, and it was quite, went through looked like a story that we were addressing from the start to finish. And it was very, very well managed. I think Dr. Rao is back actually. So I think if we have time, we'll go back to a couple of questions which has arrived at the end. If Dr. Rao, I think if you have to leave, that's fine.
No, it's just, I'm all right. Yeah.
Yeah, okay. So I think we'll go into the next session. I think the next session is a bit totally from a office practice. It goes to a bit of intensive practice, basically. Sort of, I wouldn't say office practice, but it is a day-to-day practice to something which we always fear, but always don't know how to manage it. And it is shock, and it is a very, very wide topic. And we've got a eminent faculty and panelists who will be enriching our knowledge in the particular event of shock, which Dr. Chatterjee has said, we are all in a phase of shock now over the last 24 hours, what happened on the cricket ground. But I'll hand over to Dr. Dhiren Gupta. He's quite an eminent figure in pediatric intensive care in India. He is the Deputy Director, Division of Pediatric Emergency Critical Care, Pulmonary Allergy Disorders of the famous Gangaram Hospital, New Delhi. He's the Chairperson of Pediatric Critical Care IAP 2021. He's the Chancellor of Pediatric Critical Care College 2021, Teacher for Fellowship for Pediatric Critical Care 2004 till date. He's the Course Director for Diploma in Pediatric Allergies and Asthma course. He's the President of Pediatric Critical Care IAP 2020-21. I think the list is so vast, I think it will be the end of this session if I go on. So I think rather than going through all this, I think he's already known to everyone for his eminence. So I will hand you over, Dr. Gupta, to moderate this session and enlighten us with the management of shock in children.
Yeah, thank you, Dr. Bhivan, for wonderful. I don't know whether we, deserve all these things, but I totally agree with this, from asthma to shock, and we were shocked yesterday what happened on the cricket, and don't want to listen about cricket. Now, before I go for our panel, and I would like to invite my faculty, my panelists, and I would like to introduce them. Dr. Pompa Datta Kokarji, and she's from Manchester. And good part is that she has done her basic sciences in India, so she knows a lot of things, what happens in India, what is the change which she can narrate in UK, and how we can do better. And she's been trained in GOSH and Sick Kids in Toronto, and she has got a good experience in extracorporeal devices. Now we come to a very known figure in pediatric intensive care, that is Dr. Mahesh Mohite. In fact, mine and Mahesh Mohite career in intensive care almost started together, though he's much senior to me. Presently, he's a chair IAP intensive care chapter. And very good point about Mahesh is that he has done a lot of work in poor resources. Now he's very resourceful. So he can convey us that how despite of all medical, you can say, advances, still clinical medicine is going to manage in shock also. It is going to be the prime thing. Now, the third one is Dr. Dinesh Chilla, and he is going to be chair-elect. Presently, he's chair-elect of IAP intensive care, and he is going to be next chairperson. So I am the ex-chair, present chair is Dr. Mahesh, and chair-elect is Dinesh. So it all kissa kursika, which is the which may play here, and he is MD, DM, FRCP, and good point is that he's done fellowship not only in intensive but also in neonatology. Now, in my this next 20-25 minutes, whatever Bhivan allows us. So my career started in 1993. I joined Gangaram in 1997, and today is 2022. So in fact, I'm going to talk about the approach to shock in absence of intensive care and technology, which was there in 1993 to 1997. Then we started using monitoring system from non-invasive to invasive, and we're talking about limitation and what is the future. And for all our, we all are very much experienced, especially our people who are listening to this, that most important thing is in the shock is the recognition and initiation of management. And the maximum mistake happens is the delay in recognition and initiation of management that leads to increase in the mortality. So to start with, we'll just talk about a very simple cases who come to emergency. And what happens in India especially, there's a lot of lag between emergency and intensive care. At times, intensive care is not available, or there's a delay in admission in intensive care. So in emergency, we start with only just first year, and it takes a lot of lag time, and before we start to the fourth year in intensive care. So my question to all the faculties, but we'll be starting with the Mahesh, and this is a 15-year-old male. As you can see in the video, this patient looks calm. He's having fever for past 5 to 10 days around. It was, vague history. Also had vomiting, loose motion for 2 days, pain in abdomen, and patient was really restless in between for past 24 hours. When this child presented to emergency, they look at the emergency. This is the actual vitals. Your pulse rate is 167 bounding, the peripheral and central were same. Capillary refill was flash, as you can see that. Blood pressure was 118/71. He was tachypneic, and one fluid bolus was given 500 ml. Now, Dr. Mahesh, is he still in shock? Should we call it shock? Look at the BP. Look at the saturation. The waveform is not good. And look at the child consciousness, mentation is totally fine. So my first question is he really in shock? And secondly, as per your experience, where the maximum mistakes happens in the shock management?
Thank you very much for the opportunity in this elite forum. Now coming to the case, the setting is right for shock, septic shock. Is a child who has fever, probably infection, on day 2, day 3 getting localized to GI system, and then gradually becoming sort of multi-system in view of restlessness. And then you are giving the parameters which are looking tachycardia, blood pressure, though looks okay, but CRT flash, that means I assume it's a hyper kind of a dynamic circulation with a slightly wideish pulse pressure. Is that information sufficient to label it as shock or septic shock? For septic shock, I need to define there is infection. I need to define there is a hypoperfusion of the tissue, and I need to define that there is some kind of organ failure. Perhaps that whole picture is not clearly defined here. I definitely see a tachycardia, which can be because of multiple factors, plain simple systemic inflammatory response due to fever and all. He can be tachycardic. He's showing flash CRT, but I'm not seeing that severe or kind of a significant wide pulse pressure. This is about borderline slightly higher pulse pressure, not really truly a wide pulse pressure. So there are confounders in this. One, confounded, tachycardia being confounded by many. Then your CRT flash, obviously here flash cannot be having a thing, but at times we say delayed CRT. In a febrile child, delayed CRT can fool you. You need to ideally see it at kind of a normal temperature as far as possible. Then we say wide pulse pressure, I should see drop in pulse pressure or increase of the pulse pressure to more than 50% of the systolic. And there again, which is the device being used for that? If it is on NIBP, then there are a lot of fallacies. The manufacturer itself states at a very low pressure, very high pressure, it may be fallacious. So a lot of fallacy when you go by that. But clinical setting, yes. Again, the tachypnea, it can be looking at a GI coming with tachypnea. I assume there are two systems being affected, probably heading for hypoperfusion. So yes, there is a clinical setting for shock, but I need some more information. What urine output in last 24 hours? What is the sensorium of this child? What is the saturation of this child? And those all things perhaps will complete my picture towards whether it is shock or not. Aggressive, I should be in research.
Wonderful. I think that we will require urine output also in past 24 hours. So patient had passed just once, and very well said that tachycardia can be misleading. Again, at times this is other way around also. If you find a crying child, a tachycardia of 200, and we try to ascribe to the crying, it is not good. It means a 200 heart rate is very high. So we should think of something like shock, and capillary refill with fever should be cautiously judged. And very important is blood pressure with fever. There can be wide pulse pressure with anemia, thyrotoxicosis, and with fever, there can be wide pulse pressure. So without fever, the all parameters gives you better assessment then. And very important is invasive blood pressure gives you the best idea because it is a low flow state. And one point you will agree, Dr. Mahesh, that many times in a child who is fully conscious, We go to a hospital, in a small nursing home, in a room, we find, oh my God, patient was fully conscious in the morning, he was eating well, he was smiling, and in the afternoon, he was in ICU. So what do you feel that, what is the relationship between the consciousness and the, shock part? Why it is misleading, especially in bigger kids?
Especially in the septic shock, as we call it, as the maldistributive shock, the typical kind of a progression of organ failure from not so vital to vital is not being followed. And this is particular thing which is very missed by the beginners. So you may see a child who is looking alert, but passing less urine. You may see a child who is looking drowsy, but having tachypnea distress because of underperfused lungs. So one need to take into consideration all system perfusion stepwise. If clinically not determined, then go by labs and then try to define how many systems are affected. That perhaps will help you. And again, as you said about the sensorium, that can be fallacious. It also can be affected by so many things that is happening in the ICU. You may be dehydrated. It may be electrolyte imbalances. It may be some primary infection of the CNS. So all those things have to be taken into consideration without jumping into conclusion.
Yeah,
obviously,
so perfectly said
an emergency.
A conscious child doesn't mean everything is fine. That is, I've seen pediatricians think that, okay, he was smiling and so no touch technique, so blood pressure, pulse rate, everything counts. Now we move ahead and anything you want to add, Dr. Pompa, and in the clinical assessment, as per your experience, any mistake which people do during the initial assessment?
No, I think it's absolutely spot on. Like, the child is febrile, and I think sometimes the clinical signs may be misleading. But I think what is important is repeated reassessment. And after you have done an intervention, I see that the child has got a fluid bolus. Has anything changed after that reintervention is very important to make the whole picture.
Yeah, perfect. Now we move to Dr. Dinesh. And Dr. Dinesh, this patient had skin rectal temperature difference of 6 degrees centigrade. Lactate was 6.6. This was venous lactate. SCVO2 was 95. If you assume that in this patient, it was done later, but I'm just showing here because we want to discuss this modality also. And past patient has just passed urine once. Now my question is that, means we started with my parameters like blood pressure and urine output, capillary refill time, mentation, and now we are moving towards the cell. What is happening inside the cell? Because shock is that inadequate perfusion to the cell. So cell cries two things like lactate and HCVO2. These are the two parameters which can be checked. So what do you think that, what is the importance of lactate in your practice, and do you use it, and or is it a absolute value, or is it sequence? And secondly, why we now don't call it warm shock or cold shock, and just comment on central venous oxygen saturation? I think Dr. Dinesh is not there. Okay. Can you, Dr. Pompa, can you comment on it? The importance of lactate and how you use the lactate?
I think lactate.
Dr. Dinesh is back.
Sorry, I'm back. Sorry, I just had some problem with my net.
Okay. I thought you are so busy person that you must be managing patients simultaneously.
No, thanks for that, Dhiren. See, I think as we all know, lactate has become a very sensitive marker of tissue hypoxia and a very sensitive marker of shock. And a lactate level of more than 4 is a good indicator, sort of multi-organ dysfunction or risk of mortality and other things. And when you are doing your resuscitation with a drop in the lactate, it itself a good marker that the child is improving. That is how sort of we're using lactates. So most of our now ABGs comes with a lactate value. And when we see it more than 2, we become cautious. When it is more than 4, I think we know that we are in trouble. That is what sort of we see. So I think lactate is definitely useful in not just going by base excess, but looking at the lactate. Fallacies, yes, if you have a tourniquet, if you have the way you collected it, in some inborn errors of metabolism, liver failure, you can have fallacious readings. That is how sort of you do. But lactate directed therapies are something also where you sort of balance between your oxygen demand and supply, how you can sort of is something which we are all now looking at when we are managing shock. What the other parameters which Dhiren has shown is that as the difference between the end organ, how you differentiate between skin and rectal core and peripheral temperature. a difference of more than 2 is a significant. So this 6 degrees centigrade is quite significant temperature. So earlier we were taught about when you had a difference of more than this, it's a cold shock. But on the other side, you have seen that there's a mixed venous oxygen saturation, which is 95, which we see in a warm shock. So there has been nice study which has come out saying that the clinical signs probably are poor predictors of differentiating between warm shock and cold shock. A very high mixed venous oxygen saturation is again not good, which means there is not adequate time for the oxygen extraction. On the opposite side, a mixed venous oxygen saturation of less than 70% is also suggestive that, the child is in a severe shock. And the third point, which is sort of looked at the endogenous kidneys, which is that there's a very less urine output in this child. So now for this child, the child with sort of, fever, loose motions, now we know this child definitely is in shock. He has got a very high lactate and he's got all the other features of shock. And we should be probably going for sort of aggressive management by giving him fluid, assessing whether he's fluid responsive or not, whether he needs inotropes. I think that is how we should go around.
Thank you, Dr. Dinesh. Dr. Pompa, why we are now not using terminology warm shock and cold shock? Means, are you still advocating the use of warm shock or cold shock, and or you go for something else? Why we have dropped?
Yeah, I think there are two reasons which I see. I mean, if you look at the American Critical Care Medicine 2017 paper by Davis et al., it still does categorize warm shock and cold shock. But we now have more advanced hemodynamic monitoring tools, so we can measure these indices directly. You have got bedside echo. And as my previous speaker has always alluded to, the clinical assessment can sometimes be unreliable. Like you may categorize someone as, for example, warm shock, but he may be in cold shock. And also it's a dynamic thing. It's not just static. The person who's in cold shock may evolve into a warm shock. So I think that is one of the reasons why we don't use these terminologies anymore.
Yeah, thank you. Yeah, thank you, Dr. Pompa. And just I am interrupting because we have less time and we have many things. Now, the landmark study which actually changed this concept is one which you told, and also Dr. Suchitra Ranjit. And what they found that if you put an artery line, then whatever the shock which used to be previously like cold shock actually had wide pulse pressure. So your concept of the type of shock, it actually changed, not just by touch and saying that cold shock now, so almost in 60%. So now, Dr. Dinesh, we have shifted the patient to ICU. We have shifted the patient to ICU, given one bolus. Now, intra-arterial monitoring and started, and what a contrast. Look at the blood pressure. So it is 60/30. Now, at this time, 2 more fluid boluses were given. There was 30-minute gap between emergency shifting to ICU. Like epinephrine was started by the peripheral line. So are you happy with these 2 fluid boluses blindly, or you would have done something else?
Yeah, I think, I'll take this questions into 3 parts. One is sort of the low blood pressure, which he's saying. So I think Mahesh has pointed out using this, this is non-invasive blood pressure is unreliable. And when it comes to especially diagnosing hypotensive shock, because the non-invasive will overread the systolic blood pressure and you might fall asleep. A clinical examination actually looking at your peripheral and central pulses will definitely help you to sort of actually tell you. But I think once you're feeling the child is in shock, but for planning your fluid management, inotropes, I think invasive blood pressure is what we should do. Just what I is a message I would like to give. Now, whether how many processes and other things we need to give is, I think we are using a lot of us in point of care ultrasound is what sort of is what.
I think I will come to that. I will come to that, Dinesh. Before that, just 4 or 5 questions I want to clarify. When you think of arterial line insertion, because in my experience, 2 things have changed and revolutionized the whole management of 25 years. That is intra-arterial BP monitoring and ultrasound. We'll talk about ultrasound later on. So presently, because I am sitting in a simple hospital, I don't have ultrasound. Many hospitals doesn't have ultrasound. So based on that setting,
see, if I want
I should insert intra-arterial, when I should start doing BP monitoring intra-arterial.
See, if I have to give a very practical answer, I would say whenever you're needing an inotropes,
Yes.
Whenever you're giving fluid bolus of more than say 20 to 40 ml per kg, probably that is the time when you say you should get ready for a.
Perfect. It's just a short answer and rapid sort of. So whenever a patient is fluid unresponsive and you're moving towards inotrope. Second question. Precaution while giving this inotrope through the peripheral line. What precaution you would like to keep?
So yes, you need a. Should you give through peripheral line? Yes, you should give because it takes some time to get the central line. Second is preferably more proximal to the antecubital fossa. So more closer to that is what is sort of is recommended to give. Which drug you can give sort of any of the this thing. So extravasation is something which people are worried about when you are giving through the peripheral line. So once you put it to the peripheral line, you always try to get it ready. So don't give longer than 6 hours. Always try to get your central line in once you sort of stabilize the child.
Perfect. So dilute it and give in the major vein. Now, what is the status of dopamine? Is it dopamine out? Yes or no? As a starting inotrope?
Yeah. So if you say noradrenaline, adrenaline, dopamine, that's the list. I wouldn't say out, but probably it's gone very low down in the list.
Okay. Now fluid bolus. Now we say that, okay, if you got intensive care, if you don't have intensive care backup, so in intensive care backup, you give fluid bolus and you monitor fluid responsiveness, but in where there is no ICU, there is no respiratory support, you don't give fluid bolus till patient is not hypotensive. Even if hypotensive, give fluid bolus. My question is that the type of fluid. So nowadays, it is recommended that give buffered crystalloid or balanced salt. What is your experience and what is your practice? And I would like to involve Pompa as well as Dr. Mahesh to comment on the type of fluid they are using presently. Leave the guideline aside.
See, at this stage, you have to.
Yeah. Then Dinesh, then Dr. Mahesh, and then Pompa.
We're still using normal saline, I would say. We are not yet shifted to plasmolite at this stage. But if you are giving more than 40 ml per kg, that's when we are going to colloids like albumin, especially in.
We'll talk about albumin. Mahesh, what about your balanced solution? Are you using it?
Normal saline followed by gelatin. So albumin, I don't have for Dinesh.
Yeah, Pompa.
So I think our practice has changed since some of the recent
papers. What is your practice? What is your practice in your unit?
When this child comes to ED, our protocol is still to use normal saline. If it's in ITU, we use balanced crystalloid like plasmolite.
So you use in albumin? You use in
no, we use
balanced solution.
So like plasmolite, and we do use albumin, but that's not very routine. Like after you have exceeded a certain 40 to 60 ml per kilo, then yes, we do use, but that's kind of looked upon.
So I'll share my practice that we have done thesis over the plasmolite, and so we found that it is little bit costly, around 150. So it is 1.5 pound for you and around 1 pound for the normal saline. And we found that it was statistically beneficial in metabolic acidosis. Hyperchloremia was less. And of course, gelatin is now out as per the studies, and we are also not using gelatin. We are using albumin. So 20%, unfortunately, we don't have 5% nowadays, so we dilute it. Now, having said that, means of course, over the time, things have become slowly infuse the things, even in dengue. And so over the years, we have found that not hit hard and fast, but little bit slow, especially if you don't have ICU backup. You don't have facility to judge what is happening to the fluid and what is happening to the body so fluid responsiveness and fluid intolerance. There are two things which we are going to discuss. And for you, Pompa, this is a patient who is the ultrasound finding. This is the same patient now still is not intubated, right? So patient is still conscious and there's abdominal tenderness also. He's already received 3000 ml of fluid. This was around 12 years back. So weighing, you can see. So we find that IVC was not collapsible, as you can see, and you can see the IVC and look at the heart, and it looks a little bit hypercontractile, though here you can see the mitral valve is almost touching. So it looks like hypercontractile. Now, if you given this setting that IVC is, not collapsible, could you have started vasoactive drug much earlier after 1 fluid bolus or 2 fluid bolus, not given too many fluid bolus? how you titrate fluid bolus in emergency, how you titrate, do you have ultrasound machine for fluid titration in emergency, or do you have all this facility in your intensive care? How you go about these things?
I think point of care ultrasound, it is like an intensivist stethoscope currently, and the practice is coming up. We are also training our emergency physicians or the trainees to use point of care ultrasound. The caveat is, I mean, it depends on a lot of things. And as you know, there are also some fallacies with IVC assessment. And I think as long as the user is familiar with those fallacies, like it depends whether your child is spontaneously breathing, not breathing, whether the child is intubated or mechanically ventilated, are you on CPAP? And also a lot of other things which determine that. Now, obviously, it is helpful, and there are a lot of parameters which help you to guide fluid responsiveness. The problem is the normative data in children is not available.
Yeah, which parameter you use for fluid responsiveness?
So we do look.
Just tell us 2 parameters. Looking at those, I will give fluid, and these 2 parameters are, if not good, I won't give fluid.
So we do look at the IVC collapsibility or distensibility if the child is mechanically ventilated. And then also we use the velocity time integral sometimes, but obviously that requires correct assessment of your aortic valve area. So that is not commonly used, but we normally use at the IVC diameter, and also general eyeballing of your 4-chamber view, like, you know, if the LV looks kind of fluid depleted.
Perfect, Pompa. Yeah. Mahesh, which 2 parameters you use in your clinical practice about the fluid responsiveness? And same, I want comment from Dinesh.
I put my echo probe on the IVC as well as simultaneously I put my probe on the lung. I initially check the A lines and I see the appearance of B line. Perhaps that's far more sensitive than the IVC today. So if the child is like this particular child who is generalized sepsis, more as no respiratory involvement, here perhaps I'll be following my B line appearance. So I will be pushing, first of all, 360 ml per kg, and before that, no inotrop. I think it's not today. It was maybe 20 years ago. They fill up the compartment and then start inotroping. Today, we are simultaneously doing some maybe 20 ml per kg. This is a septic shock scenario. So 20 ml per kg, that also is really higher end. I may be going with 10 and monitor again 10 and quickly add inotrop, and then I may titrate subsequently. And for titration, I'll be looking at the B lines apart from my clinical of dropping heart rate. Maybe I'll keep checking the liver size. I'll keep checking clinically about the saturation going down as a response to fluid, tachypnea coming up further.
Agreed. Totally agree,
I'll be going
Mahesh, and I totally agree that 3000 fluid is too much. One point I want to convey, from the Dr. Dinesh, what about the ceiling fluid? Means, is it a ceiling like you get means predicted body weight of 50, 60? What should be the one fluid bolus in these kids?
Are you saying that what should be the maximum fluid you're saying? Is that something you're saying?
Not maximum, one bolus. Like we say 10 ml per kg. So 70 kg, if predicted body weight is 70, so are you going to give 700?
Okay, like that. No, most of the time you give 500 ml. Suppose if you're someone like that, if you give 500 ml and then you look for, if you're saying that at the first bolus. But as Mahesh said, see, we are in an era where we do not know whether it's a cardiogenic shock or the septic.
Yeah, I totally agree with Mahesh. I think
you give in a bolus of 500 and review it if it is a big child. But in another child, you go now 10 to 20 ml and then reassess every time. So what happens? So the next bolus, you don't give 20 ml, you give 10 ml and reassess if it's fluid responsive.
So if you're skeptical about cardiac involvement and if you don't have ultrasound, you may give 200 ml and give fast and look at what is happening to the child. And Pompa, what type of fluid or not, what is the amount of fluid ceiling dose if you get a 50 kg child and likely non-cardiac? Though I know you work in cardiac center, but I just want that. What is the practice in the gauche and what is the ceiling dose of fluid bolus in a patient like this?
We would usually have weights for all patients or an estimated weight. The fluid titration is based on ideal body weight. For example,
suppose ideal body weight is 60 now.
So 60, then we would give up to 500 or so. 10 ml per kilo is we would give. And also, you know, this is in Western countries, as you know from the FEAST trial, there was, which was done in sub-Saharan Africa. So obviously there was increased mortality with fluid bolus in children who didn't have hypertension. Now, the
Yeah.
population we are talking are children who have hypertension. So we are actually a bit generous in fluid administration in the UK.
So I mean to say the ceiling dose is something like 500. You're not going to give
Yeah,
exceed that,
500.
right?
Yeah.
Yeah. So now we move to a child where we have whatever we have discussed, we have used it. 4-year-old child, fever for 4 days, refractory shock, and he's been transported. During transportation, adequate amount of fluid was given. Dopamine, that was again, it was around, I think, 15 years back when we used to use dopamine. Dopamine, norepinephrine, epinephrine, vasopressin, and steroids were on, and 56 by 36, 8 by BP. So it looks like as we are on the verge of cardiac arrest, there were hardly any peripheral pulses or central pulses were also lost. And to our surprise, ultrasound showed in the subcostal region, it was variability, which was, and also showing cardiac contractility, which was in fact hypercontractile. And looking at the all parameter that gave us confidence that we should push in more fluid boluses. And this patient was given albumin, and you can see over next 1 hour the blood pressure became normal. So this patient required massive blood transfusion, and ultimately this was we have to do de-resuscitation in form of CRRT, and lot of things happened. The patient survived. Now my question, actually you have already answered, Pompa and Dr. Dinesh, that fallacies of IVC is that patient should be intubated, then it has got better sensitivity and specificity. And the last point, which everybody has already talked, that look at the eyeballing, and Pompa also discussed that look at the cardiac status, there's a kissing heart. So it looks like on the left side, it looks like as a kissing heart and hypercontractile. And once the resuscitation is there, you can actually look at the end diastolic volume in the heart, and that gives you an idea what is happening inside the heart. So now my question is something different, and for everybody, and I will start with the Pompa. We talk about clinical, we talk about ultrasonography, and for almost 10-15 years, we use many cardiac output monitoring facility like PICO, USCOM, and lot of other facility, but we were never satisfied. Ultimately, clinical plus ultrasound, these were the only two modalities which we are working. And honestly speaking, we are not convinced till date that any cardiac output monitoring system, especially if you've got a trained doctor inside who can do ultrasound at the bedside, they are the best. So what is your take-home message, and what message you want to convey about continuous cardiac output monitoring, where cardiac output, heart rate, cardiac index, and SVRI can be measured?
I think I've worked in units which use this, and I've worked in units which don't use it, and I don't think the outcomes are any different. The problem with continuous cardiac output monitoring is you need people who know. I think again, it is calibrated, like, we have the PICO, which uses thermodilution, for example. The problem is it gives some numbers which no one knows how to interpret. And it needs frequent calibration. And it doesn't help in bedside titration of either your tropes. Like, yes, if you do it on the basis of the number, but again, the next time you look at it, it doesn't change much. So I think we are not quite attuned to making sense of these numbers, and also having a normative data for all children who are critically ill. So in my view, we don't use it, and in our unit, we don't use it.
Thank you, Pompa. Dinesh, anything else what she has said? Anything you want to add? And Mahesh?
We still stick to, I think, as you rightly said, more for ultrasound and clinical parameter, not using cardiac output.
And Dinesh?
No, I was just wondering this aspect of USG guided cardiac output in index monitoring. We need to understand a lot of operator ability. Yeah. So a person should be adequately trained, qualified, and experienced to interpret in a critical scenario. So I think it's just one part of the whole spectrum: the upstream parameters, downstream parameters, clinical recognition of the tissue perfusion, complemented by USG. Perhaps that will give you a good storage. You cannot be adjusting. Adjusting the patient volume.
It is always a masala movie which helps rather than VFX induced movie, right? So now look at this 1.5 hour we are in, and diffuse pain in abdomen.
You've got about 7 minutes, Dr. Gupta, to wrap up.
Sir, we started at 7:05. We started at 10:05, right?
Okay, carry on.
Yeah, so I'm calculating each and every slide time. I've got time in that. So 10:05 we started. So I think previous discussion actually exceeded the time. So we'll finish off, don't worry. So at 1.5 hour, there's a diffuse pain over the abdomen. Look at, I'll show you. Look at the patient is so moaning. because without this sound, no one can understand what is the pain. And now this patient is still hypotensive on epinephrine, norepinephrine, pulse rate is 175, saturation 98. Patient, though in between is calm and quiet, no respiratory distress, ultrasound is showing mild fluid in abdomen, a point of care. And means what should be our next step? Should we intubate this patient who is not having respiratory distress, pompa? Like, because we consider this is a refractory shock. What you would have done in this patient, and what precaution you would like to take during intubation, and what can happen to this child while intubating this at this scenario?
So I think we're dealing with fluid refractory and almost on the verge of catecholamine resistant shock. I don't know if the child also had steroids. So this patient would be intubated in my unit much earlier. The purpose of intubation is
exactly. I think everything. Dr. Dinesh and Mahesh agree that patient is in refractory, we should intubate now.
Absolutely.
So again, what message you want to give, especially if you try to intubate, what can happen to this patient and what precautions?
I think the precaution is the child can arrest. There's a 10% risk of mortality during induction. So you need to be really cautious about what drugs you use, and also to know the to use of the drugs for induction. Actually, you need something which is cardiostable. I think I would not use propofol to intubate this child, because you can have a sudden drop in your SVR and you might crash. So that is one thing. So usually in our practice, we would use something like fentanyl or ketamine.
So we'd like to watch for the cardiac arrest and fluid resuscitation, inotrope resuscitation, and use drugs like ketamine. Now, just one point. At this patient, this looks like something happening in the abdomen. Now, BP is also 80/30, and you intubate, and patient is not responding to fluid. Would you subject this patient to the theater, or would you ask the surgeon to put in a tube here? There's something is happening inside the abdomen. What is your practice in your unit, how you are able to convince the surgeon that take this patient with 80/30 BP in the theater? And what about Dr. Dinesh and Mahesh? Please, one line from your side.
I will put a tube in this child if I am correct.
Okay, so tube. Yes, pompa.
I'll put the tube inside, drain it.
So what we have done is the surgeon comes to the unit and assesses the patient, and we have done it in the unit sometimes, especially in smaller babies. I think your child is slightly bigger. We need buy-in from the anesthetist, and I think source control is very important in sepsis, so that is why I think it has to be done. Now, there is a risk. I think as long as you explain the risk to the parents, I think that's okay.
So Pompa and they rightly said that if it has to be done, it has to be done, because unless you don't control the source, the patient, you are anyway you are going to lose, right, Dr. Dinesh?
Yeah.
So we move to 4 hours. Say another 3 hours, we found that the patient was intubated, lactate was high, tachycardia persisted, abdominal distension was there, and the patient was taken to theater and 500 ml per drain, and though BP became better, but patient had lot of problem later on. So we have learned now.
Just one quick question. Just one quick question. Was it a drain put or he was explored?
No, he was explored. He was explored, just the pus was drained, and we got back in, so our resident was there throughout the surgery, and he monitored along with anesthetist. Now we quickly.
I just give one message here. Then we see what happens is, as Mahesh says, see, when you have something like that, if there is a pus, sometimes you just put a drain.
Yes.
To get the blood pressure up, stabilize, and then explode, because otherwise just the process of
risk
might kill a child who probably otherwise would have survived.
Anesthesia risk is extremely high here.
So I think there could be a balance there. That's what I would say. But
so again, depending, because what happened, the repeat ultrasound shows lot of septate. So that's why we took the decision that probably one tube is not going to suffice, and there were many pockets of pus. That's why initial ultrasound did not reveal the actual pus, and the point of care ultrasound, we actually missed that. So regular ultrasoundologists told that there are a lot of pus and there was small perforation, because it looks like antique perforation. We have got around 5-7 minutes. Don't worry, we'll finish it next 5-7 minutes. These are different scenarios. These are actually cases of cervical cord trauma. This was a road traffic accident, 3.5-year-old male with blood pressure of 70/30. There's a vasoplegia with bradycardia. So that is a usual. This was a recent child, a 16-year-old male with spinal cord trauma. During swimming, he land up in the shallow swimming and is suffered fracture of the neck. And now these two patients are of spinal shock. We all know that neck stabilization, which is lacking in India, is a major problem in India. It means road traffic accident, neck stabilization looks like out of course, right? We all know that it should do. We all know that it's a vasoplegia. We require a lot of vasopressors and fluid. My question is to Dr. Pompa is, what is your practice of using methylprednisolone at there? Because now it is saying that it is doubtful, even if it has come within 8 hours. So what is your practice? And also I want answer from Dinesh and Mahesh, one line.
I think we still use it. It has been proven to be beneficial in animal studies, but not in human studies. And it's also very neurosurgeon dependent, because I think you'll get the surgeon if you have traumatic spinal injury. So I think it depends on discussion, but the tendency is to use it.
Yeah, thank you, Pompa. Dinesh, what is your take-home message?
Our neurologists and neurosurgeons still believe in it. I think so. We end up giving it.
So we also used. I'm just talking about real and real. So both are things. And
so there is no definite harm for the short-term use. There is no definite harm for the short-term use. So use it. Whatever it helps, helps.
Okay, so we move to the last case. That is the dengue season is going on, and we'll exclude Pompa. She'll say we don't see dengue there, so it's fine. Dengue, it's fine. Pompa, you can relax.
Thank you so much.
Yeah. So 1 year old, and it goes to Mahesh and Chilla. It's a dengue shock. The 7th day of fever. Understand, this is 7th day. 12 hours of treatment. Severe tachycardia persisting. Massive IV fluid requirement is there because patient was almost fluid dependent despite of inotrope, multiple inotrope. Now, Mahesh, we know that hypovolemia and bleeding is one of the major cause of shock in dengue. What else we should think at this stage, which is very common nowadays?
Hypovolemia and bleeding would come on 3rd or 4th day. This is a bit too late. So whether it's sepsis is catching up or macrophage activity.
This is abdomen. This is abdomen. Look at this is abdomen.
Yeah, absolutely. So he's a abdominal compartment syndrome. There's obstructive shock coming up. It could be bleeding inside, which is causing problem. Not to forget, child having refractory shock at this point of time, it can be macrophage activation. And that also has to. So basically, dengue has to all kind of possible shocks. Capillary hypovolemia.
2 points. 2 points I want to emphasize that other than just hypovolemia, obstructive shock and your macrophage activation that behaves like a septic shock. Absolutely. Right, because it's a hyperferritinemia stage, so it is a hyperinflammatory. Now, can you clinically differentiate? Suppose this patient is not having fever. Does the pulse pressure is going to differ if it is a purely obstructive shock and if it is a vasodilated state like hyperferritinemia?
Absolutely. In case of vasodilator, you will have wide pulse pressure shock, and in case of obstructive shock, it will be narrow pulse pressure shock. That's a gross thing that we can do if you have an invasive line. But again, I hope you have put the invasive line far because now his platelets are gone down to 10,000 and it's going to be another catastrophe and disaster. So I'm sure this is becoming sick and ongoing sickness for more than 2 or 3 days where all your lines are in and you will be in better position to detect that narrow pulse pressure or wide pulse pressure. Clinically, it's very difficult. As we said,
Mahesh, one point I want to convey to all the listeners and viewers. Whenever we get fluid unresponsiveness or more than 40-50 ml fluid if patient is required, we put in first thing we do is an artery line. That is one thing which has changed the whole management. That I would like to convey. Now, in this patient, the abdominal pressure was high. In fact, we measure abdominal pressure in all the cases where patient had some refractoriness or in patient where we feel that leakiness is going to be there, irrespective of clinical examination. What you do, Mahesh and Dinesh, and I won't ask Pompa.
No, I don't measure in every patient unless I definitely see some kind of a distension and increasing abdominal girth. So once abdominal girth is increasing, definitely we'll measure the pressure. Not to forget, obstructive shock not only comes from abdomen, it can come from pleura and as well as pericardium. One which is very commonly missed is pericardial fluid. That's where your focus, your recurrent use ultrasonographic examination in this refractory shock is it. I have seen the patient who is being referred for refractory shock. There's a significant tamponade.
You told us, you shared us. Dinesh, you answer it, and now the last one is going to be for the Pompa.
Yeah.
So
We measure a little bit more frequently because we are getting a lot of children who are leaking into abdomen. If your fluid boluses are crossing, sort of say, you end up, see, we tend to give the colloid little early in dengue compared to the other shocks. Number one, that's what the message I would like to give. Second is, yeah, we measure the intra-abdominal pressure because sometimes the girth may not. You also measure look at the urine output. That also gives you some clue about what is happening. Refractory shock, certainly. These are three things which we follow, and go for early renal replacement therapy or putting the PD drain and trying to get.
I'm coming to that. This is the last slide, and we'll winding up our discussion. This is a case of refractory shock, 12-year-old with low-grade fever for 1 month, and 12 hours patient is hypotensive. So, Pompa, I am going to ask you, in this patient, we find that right ventricle was getting enlarged and enlarged whenever we were giving fluid. Second part is, do you use NIRS in a patient of shock, like you put in an NIRS in the back at the renal angle, and you try to look at the non-invasive, measurement of the renal perfusion? So when you use NIRS, because we know that in cardiac cases, in intraoperative and postoperative, we use NIRS. So in septic shock, have you used NIRS? And secondly, in this, if you find right ventricle is getting enlarged when you give fluid, what other differential diagnosis we should think?
Please unmute. Please unmute.
So using NIRS, we use it in cardiac ITU. I mean, NIRS, the probes are very expensive. So I think we are limited by cost in using it in all patients. But in select patients, we would use it both cerebral and kidney NIRS. But it's not routinely practiced. So that's what I want to convey. Secondly, if you have got an RV dilatation, I think you need more images like what is the TR velocity, and also is there anything in the lungs, because that is what is going to cause an acute RV failure. Are you ventilating this patient on very high volumes or pressures? Because as I can see on the X-ray, there is some collapse consolidation. I think if you're ventilating on normal tidal volumes or accepted tidal volumes, and you still have kind of an RV dilatation to that extent, you do need to subject this patient to a CTPA to rule out pulmonary embolism. I think that is what I would do.
So in this patient, wonderful, Dr. Pompa, we missed the pulmonary embolization in this case. And our cardiologist suspected that there must be embolization, and we found it was embolization. Now, the last question to everybody. Normally, past 2-3 years, we are using a lot of filters like Auxerase filters and cytosorb whenever we find there is a lot of cytokine storm happening in the patient. We use CRRT very often. So what is the indication of CRRT? Do you use these filters, Pompa, in your unit in septic shock?
So I know that it's used in the liver unit, like Akash uses a lot of CRRT, but what we have seen is actually that our renal replacement therapies are actually lower, quite low. We use it in conjunction with ECMO, but isolated renal replacement, I think, we don't see that often, and I don't know why, but our rates are not as high as it used to be before. I think the specific indication, if you read Carcillo's paper, is thrombocytopenia TAMOF group, where we used if you have purpura fulminans. But I believe that is related to vaccination. We don't see that many meningococcal either. So I think that is why that has been.
So probably you don't get that type of neglected shock which we get in India. What about Dinesh, use of Auxerase filter and cytosorb? How frequently you use it, and what is the indication if somebody can afford it?
Yeah, I think, see, we use in between quite a bit cytosorb, and we're slowly going away from it, is what I would say, because the evidence we are gathering is whether it really works, and it has been equivocal. And we review the literature that's showing the same thing. It has been used for children, as you say, with cytokine shock, refractory shocks, and not responding to the treatment. CRRT, we have lower threshold than sort of whenever a child we have sort of a shock with the evidence of acute kidney injury, a lot of fluid overload. We would like to get the fluid, removed. So we try to sort of see that, keep them dry. And we found that, it does help, and it definitely improved the outcomes of the babies. But when to add cytosorb, I think it is a lot based on, whenever we thought there was a cytokine storm. Oxyrese, again, from adult studies, people got very excited. They used in septic shock quite a bit in between. They added the tobramycin. They looked into different sort of this, but didn't really make that big a difference as, and for the cost, I don't think that is worth it. So looked at the recent reviewed it and looked at the recommendation. I think the recent recommendation does not say that really makes a huge difference. So I think it's
So
sometimes
practically, you may select some of the patient, but it's not clearly recommended. The last point is the ECMO. Other than cardiogenic shock, we found that if it is a vasoplesic shock, especially in dengue or septic shock, it do more harm than the benefit. What is your indication of ECMO in a patient of refractory shock? One line from Dinesh and Dr. Mahesh Mohite and Pompa. I'm not talking about cardiogenic shock. I'm talking about refractory septic shock or refractory dengue shock.
See, anyone...
Because we have stopped using ECMO in refractory septic shock and refractory dengue. We have found that it harms, especially if your vascular leak is there, and so it doesn't help.
I don't have so many patients to tell that so dogmatically that it is definitely contraindicated in that, to be very honest. Whatever patients we have used, we have seen patients in refractory shock or children who have bad arrhythmia went to shock. That's where we have used ECMO, but not in septic shock. So I think that's what I would say from our experience.
Mahesh?
No, honestly, both the setup that I work, I don't have much experience with ECMO, especially in this septic shock scenario. So I can't comment on that.
Pompa?
So we do around 30 ECMOs a year. I think the evidence is that previously it was a contraindication in septic shock. We wouldn't put septic shock patients on ECMO, mainly from adult literature, because it is limited by the cannula size. And if you're especially in a hyperdynamic circulation, you cannot match that cardiac output with an ECMO circuit.
Yeah.
And the size of cannulas do you have. Now, if you have sepsis with myocardial dysfunction, we may put occasionally on ECMO, but our outcomes are not fantastic. But I know that in high volume centers, the survival is around 75%. It just depends. But usually you do get a lot of filter issues and coagulopathy and all. So even if there is survival, I think the morbidity is high. You end up with other complications. So our practice is, if you're having sepsis-induced myocardial dysfunction, but it is not for all patients. For example, the other day I had a patient who was on 0.5 of adrenaline, 0.3 of NORAD, and 0.3 of milrinone. And I think it is a dynamic assessment. If your gas exchange is acceptable, like you have a PO2s of, I think for that patient, I had a PO2 of 8 or 7.5, CO2s were around 7, with pH was 7.1 for a period of time. But the child did turn the corner. And at one point we did consider ECMO, but eventually got away without it. So I think it has a role. I would not like to take it completely from the armamentarium, but it has to be selective. We cannot put everyone on ECMO.
Yeah, wonderful. Thank you. And I totally agree that cardiogenic shock, if patient is having, then definitely this is one of the modality. And I thank all the panelists for wonderful practical discussion. And if we conclude our presentation or our panel discussion, of course, means maintenance fluid is to be given if no hypotension. If hypotension is there, then slow fluid bolus, especially if there is no ICU backup. You don't have ultrasonography to look at what is happening to the fluid and what is happening to the body when you give fluid. Also, when you refer any patient, if you're referring to any other unit, try to give some fluid. At least try to have some blood pressure, systolic blood pressure, and capillary refill time. Otherwise, mortality is going to be very high, because every hour counts. Even if you are just managing an emergency and you want to refer because you don't have intensive care, at least start inotrope, give fluid, and you don't have any facility. Dilute your inotrope and give fluid, and at least systolic blood pressure should be maintained. So it is said that you reduce the mortality by 15% if you are able to just manage CRT and blood pressure. Pulse pressure is very important. It's a surrogate marker of stroke volume. So want to differentiate whether this is cardiogenic or if in absence of fever and anemia. Pulse pressure gives you good idea about the stroke volume, what is happening, even if you don't have anything like ultrasound, echocardiography, or any invasive arterial monitoring. Of course, we know that ultrasound is a non-invasive, is a good guide to therapy, but we need to get trained. And arterial blood pressure is must in fluid refractory shock. And I again thank to IAP for giving this wonderful forum. And again, back to Bivan.
Thanks, Dr. Gupta. I think if you can, all the panelists can put their cameras on. If, Naveen and Dr. Chatterjee. Just, I think there are just, I'll put one question each to either group. The first one is for Naveen because he's there. I don't think Indo is here anymore. So there was one question on the group saying, what's the difference between bronchial asthma and wheeze-associated recurrent lower respiratory tract infection in children? So I think what the meant was, what is the difference between wheeze-associated, infection-associated wheeze and bronchial asthma, and what is the marker? What is the sort of a line that we draw between them when we say, no, look, this is not wheeze-associated infection anymore, it is asthma?
So bronchial asthma, so the basic mechanism is the same. So you have hyperactive airways, but in bronchial asthma, that hyperactivity could occur because of multiple different reasons, including A to P analogy, whereas with wheeze or wheeze-associated, virus-associated wheeze, it's always triggered by an infection. So if a child is getting symptoms not associated with infection, i.e. interval symptoms or exercise-induced symptoms or symptoms associated with hay fever of obstructive airway disease, then that would be more likely to be bronchial asthma.
Thank you. Thanks, Naveen. And then one question for the team from shock. I think we cannot conclude anything without a touch of COVID. So there was a question saying, how do we manage shock in congestive cardiac failure associated with MIS-C? I mean, COVID-associated MIS-C.
Normally in MIS-C, and it is fluid refractory shock, and you need to give some inotrope like epinephrine, and you give steroid and IVIG. So anti-inflammatory therapy as well as catecholamine, and the recovery is usually wonderful. Okay. And in fact, later on we found that steroids almost work equally as IVIG. So need not to go for such an expensive therapy. But of course, if patient is in shock, you need to give 10 milligram per kg of the methylprednisolone. Any comment from the Dinesh or Mahesh?
Yes. I think you got it spot on. So we have
steroid upfront and IVIG maybe on the second day, because already in cardiac compromise. IVIG will add to the volumes which can cause further problems. So first day steroid, maybe after 12 hours with slight stability, you can give IVIG.
Yeah, Pompa?
I think there is equipoise, isn't it? So I think we have changed. Initially, we started with IVIG when there was this big, it's kind of an elephant in the room, MIC. I don't think we still understand it very well. So we started with IVIG and steroids, and then we have now shifted to steroids.
Yeah, but that is a problem with the developing country. They start with the expensive therapy, then we start with the expensive and we lose all money. Then you say, oh, that was not good. It was fine to give the steroids, right?
But we had one patient who we had to put on ECMO with MISC. I know, but our incidence of cardiac complications in my institute wasn't that high, actually. Yeah. We didn't have, it did resolve by 6 months, most of them.
Right. I think it's nearly 11 in India, isn't it? I think that's the problem with the winter time. I think we'll have to start a bit early while we're in winter.
10:45.
Yeah, so I think thanks a million to all the faculty from both our Indian friends back home and our UK friends here. Thanks to Pompa, thanks to Naveen, thanks to Dinesh, Mahesh, and Pallab and Dhiren Gupta. I think it was a very, very enriching thing. I think we'll have a look at the audience poll later, but I'll send it across in both the groups. But from behalf of IAP UK, which we've just started, it's a small group of about 20 people, which we have gone together and try to bring this enriching culture of sort of exchanging our views and exchanging our thoughts and exchanging I think medicine probably is just the same, it's just the variation of practice that we have in the East and the West, basically. So I think it's a wonderful platform, and there is a plan to meet every quarterly, and I think that is the target on the current scenario that you're having with these weighing 1 or 2 topics which are of relevance to all pediatricians all over the globe, basically. I thank you again. Ramesh is not here anymore, nor is Upendra, so I'm not sure whether they're here now. I can't see them on the screen. But thanks again for IIP and to all the panelists and the moderators who have made this a very, very interactive and useful session. And thank you all. I'll hope to see you again very soon. And good night, and see you all.
Yeah.
Thank you.
Thank you.
Thank you.
And thank
Have a
you.
nice
Thank you,
weekend.
Mahesh.
Yeah.
Thank you,
Thank
Pompa.
you.
Thank you.
Bye.
Thank you.
Bye.
Good night. Thank you. Bye-bye.